Good afternoon, and welcome to the virtual town hall for August 21st. Thank you for joining us today. As always, I must express my admiration and appreciation for all that all of you have done and continue to do to advance our missions. Today, the focus of our town hall is recognition of the challenges imposed on you and on all of us over the last several months. The frenetic pace, the necessity to adapt to nearly constant change in all aspects of our personal and professional lives, and the related stress has exacted a toll on you and on all of us. Evidence of that stress surrounds us and has been clearly expressed, and we all hear you, and I hear you. Now, many of you have the additional concern of work and family balance and the needs of family members you care for, whether school-aged children or elderly parents or others. A major topic of today's agenda is the Family Care Task Force, which was recently convened to better understand the specific needs of our workforce. Helen Morgan and Brian Zink will discuss the objectives of the Family Care Task Force and the results of a recent survey about family care needs. Ultimately, this task force will make recommendations on what interventions we, as Michigan Medicine, can make to better support our employees. We've also heard many concerns about wellness as we continue to ramp up our planning for a potential second wave of COVID-19. Kirk Brower, our Chief Wellness Officer, is on the agenda today to discuss the outcomes of a recent survey about how we're coping with COVID-19 and how we can respond to that. The Wellness Office has provided resources and education, and Kirk and his office are ramping up their efforts to support all of us through this pandemic and beyond. For our part, we, the Michigan Medicine community, and all of us must acknowledge and recognize that during very stressful times like these, we may need some help. And the notion that we can continue to run at full speed, no matter what is going on, is simply not tenable. I encourage you to pause, to be introspective, and to really consider your work balance and your life balance in ways to remain productive and positive, and how we might be able to help you and how you might be able to use some of the wellness resources that are available. Last on today's agenda, Jeff Desmond will give an update on COVID-19 and our operational activities. But first, before we get to other topics that I've mentioned, Joe Kolars will provide a brief update on the safe return of medical students. Throughout today's town hall, we'll be monitoring the chat room, and if you have questions, please submit them to that chat room, and we will try to respond to them today or in FAQs next week. Now I'll turn it over to Joe.
Thank you, Marshall, and good afternoon, colleagues. Delighted to go first. University is the first word in our name. We're defined by our learning programs, and as many of you have heard before, our hospital was actually founded first and foremost to be a learning venue for our students. So that was back in the 1800s. So delighted to update you. I'm going to talk very briefly about two groups of learners. One is our graduate students. Sometimes we forget that these are the backbone of our science programs that provide the foundation for a lot of our discoveries in clinical care. We have 14 PhD and 13 master's programs, and all of those students are starting next week. We have 600 PhD, 150 masters, and actually 112 of those PhD students will be new. We've had a number of deferrals as people are trying to blend what's going on in their own circumstances with what we've got going on here. Most of our graduate students will be online, but we do have some face-to-face activities, as you can imagine, for the labs, and we're incorporating how our students come into the labs, much like we're dealing with our faculty. Our second group of students, of course, is our medical students. Our first-year students are back. They're in their fourth week. We had to have a kind of a deferred white coat ceremony that we usually bring people into the profession. The curriculum is largely virtual, but on average, one person experience per day or per week is taking place, such as for anatomy, doctoring, all with the appropriate safeguards and the PPE that we have to use in our environment. Our second year medical students will start the end of this month. They spend a few weeks transitioning into the clinical arena through what we call a transition to the clerkship. This again is largely virtual, but a lot of the clinical skills and hands-on activities will bring people together face to face. And then finally, our third and fourth year students have actually been back in the clinical environment since early June. We consider them to be essential members of the healthcare team. Sometimes it's easy to say, well, the students are more peripheral, they're more marginal, but we really do think our teams work better and that patient care is improved when we have learners involved. So they're very well integrated, like all of our healthcare workers are, through the Office of Occupational Health Services. Two final points. One is it's a different year for our learners. Our medical students and people applying for residency, they have to actually interview virtually. So people are just getting ready for that. People are not going to be traveling to other institutions to interview, nor are we having any visiting rotations, either bringing in students with very small exceptions or having our students go to other institutions. Kind of a hot button issue we're working on with the greater university is what we're doing right now with our learning spaces. Since there's so much going on virtual and online, not all of our students have quiet spaces at home or necessarily the Wi-Fi connectivity. Meanwhile, our spaces are in short supply in the library, and our library is considered a university library, so we need to share it to some degree with the wider campus. So everyone's going to be clamoring for learning spaces, and we're working on that right now. But our students are pleased to be back, pleased to be part of all that we're doing, and we're glad to see them. So with that, I'm going to turn things over to Brian Zink and to Helen Morgan.
Thank you, Joe, and thanks for giving us the opportunity to provide an update on the work of the Family Care Task Force. I'm Brian Zink. I'm a Senior Associate in Faculty Development and also Professor of Emergency Medicine, and joined by Dr. Helen Kang Morgan, who's a Clinical Associate Professor in OB-GYN. Next slide, please. So it's no understatement to say that in the past 6 months, this little red speckled demon, the coronavirus, has changed civilization globally and life as we know it. This word cloud highlights the tragic impact on patients, which so many of us have seen firsthand. But notice also the words in this word cloud of family and care in this collage. Family care needs are a huge concern for a large portion of our Michigan medicine workforce, whether it's finding daycare or the fact that our schools, many of them have gone fully online, or caring for a disabled adult or elder care in the home. The pandemic has made things a lot more complicated. In response to this, we formed this Family Care Task Force about a month ago. It came out of discussions in the med school that were led by Dr. Carol Bradford, our Executive Vice Dean for Academic Affairs. And I was pleased to serve as co-chair along with Amanda Thatcher, who is our Chief of Staff and Director of Communications in the medical school. We then recruited Melissa Dorfman from Faculty Affairs to serve as our project manager, and we're glad we did. She's done a wonderful job with this. So next slide, please. The objectives then of our task force were to first identify the current state, both within the university and the community, in terms of family care resources and their accessibility and availability. We then sought information benchmarking with local, regional, and national organizations and peer institutions about what they're doing with family care. We are seeking to identify the issues and barriers that are impacting accessibility and availability, and then hopefully we'll get to the point of proposing solutions. We realized for this to be meaningful, we had to do it in about a 6 to 8 week time window to accomplish these objectives, and trying to do it while everyone's trying to take well-deserved vacations, well-needed vacations over the last couple of weeks. Next, please. We recruited and convened a diverse group of people who are across job families in Michigan medicine, including learners. Here's the makeup of the task force. I won't go through all the names, but just to say thanks everyone for your enthusiasm and ideas and for meeting on short notice and doing a lot of work over a short period of time. Next, please. So we came up with a plan. We're working to determine the current state of family care in Southeast Michigan, what % of child care centers and schools and elder care centers are open, and what's their capacity, things like that. We're looking at the educational plans for those school districts where most of our employees have their kids going. And we'll hear in the next few minutes about the initial results of our family care needs and work adjustment planning tool, the survey that you received. Last night, we held the first of our focus group meetings, and those will continue in the coming week. So we're in a learning phase now, and we'll be able to fill in this blank slots on the right in terms of proposed solutions in the coming weeks. And now Dr. Kang Morgan will go over data from our planning tool. Dr. Kang Morgan has done prior research in parenting and family care, so she brings a real expertise to this area. So Helen?
Thank you, Brian. I'm excited to share some of our preliminary data and broad overviews of what the community shared with us. So we sent the instrument out to 30,389 Michigan medicine faculty, staff, and learners, and we were able to get about a 21.4% response rate. So thank you to the 6,000 plus people who shared their responses. As you can see from the pie chart on the left, 82% of our respondents were female, and the table on the right shows the % of respondents that were in each one of the different HR job families. Next slide. So the pandemic has significantly impacted our family care needs. About 69% of respondents reported that they had dependents, and of those respondents, 89% reported that COVID-19 has impacted their family care arrangements. Next slide. These challenges have been hard on us. We asked, what is the impact of your increased family caregiving responsibilities on well-being and burnout, with the dark blue representing to a great extent, to the light blue being to some extent. The dark yellow is a small extent, and a yellow is non-extent at all. And you can see from the bar graph on the left that about 80% of our respondents reported that the increased family caregiving responsibilities were impacting their well-being and burnout. The bar graph on the right shows that about 60% of our respondents felt that it was impacting their career productivity and/or their trajectory. And reminder again that 82% of our respondents were female, so these findings are really important to note. Next slide. The respondents talked about multiple disruptions that COVID-19 has caused on their childcare arrangements. The top two were related to all of the challenges related to remote learning, with schools offering only online learning or reduced hours, how online learning requires support. Other disruptions include working from home with family members present is challenging, family caregivers are not available. Other disruptions include financial pressure, changes to daycare, paid caregivers not being available, and a small % of our respondents reported that they were expected to increase their productivity or work longer hours. Next slide. There was a wide range of barriers that respondents felt they were finding as they were trying to find dependent care solutions. This bar graph shows the top 5 barriers to finding dependent care solutions, the top one being concerns about caregivers bringing exposures of COVID-19 into my home. Again, the lack of in-person school, financial constraints, concerns from caregivers that I would bring COVID-19 given that I'm a healthcare worker, and then again, the lack of flexibility in my work arrangements. Next slide. We asked how many hours of dependent care per week are not covered by existing arrangements, and you can see there was a wide range of hours that are not currently being covered, but more than 50% of our respondents felt that it was about 20 hours a week or less that are currently not being covered. Next slide. In response to the question about what dependent care options are under consideration, a large proportion of our respondents indicated that they were looking for flexibility. The top response was adjusting my work schedule while remaining full-time, The one below is structuring my job in a flexible way to allow me to provide care during work hours. Other dependent care options that our respondents were considering were relying on a family member for caregiving, reducing my current effort, finding an in-home caregiver, trying to find a student or a tutor, trying to find a shared caregiving or tutor with one or more families, taking a leave of absence, finding a school-age childcare spot, finding a daycare spot, or stopping work to stay at home full-time. Next slide. Lastly, while some of our respondents were looking to reduce their effort, nearly half of our respondents marked they did not know yet what they were going to do as they were looking for family care solutions. Next slide. And then Brian, did you want to?
Yeah, just thanks for presenting that, Helen. I think we learned a lot from that initial look at the data. We're going to do a deeper dive and present this to departments and all of the job families across Michigan Medicine. Just want to point out that this website, these resources, you might take a picture of this with your camera right now, because there's a ton of information here about resources, about the focus groups. It's just a lot of information. So please access this if you have any concerns about family care, because this is a great resource and we're updating it almost every day. So please check this out. I think you will find it helpful. Next. So in closing, just to talk a little bit about solutions. So on the left are the things that we're using to gather information. And on the right, potential solutions we think could involve changes to policies, our operations, potentially benefits, and then just trying to access the expertise in Michigan Medicine to try to figure out some solutions for this problem that is going to be with us for a little while yet. So in closing, we're all struggling in these challenging times, and family care is one of the many issues we're dealing with, but we're showing remarkable strength and resilience, I think, in many ways. This won't last forever. We'll get through it as long as we stay together and support each other and have hope and an innovative spirit. Thanks for letting us share the results of our task force work, and thanks to everyone who contributed to the Family Care Task Force, and we will be hopefully communicating with you further as we have more information and ideas. And now I'm happy to introduce Dr. Kirk Brower, our Chief Wellness Officer, who will provide the next section of information.
Hello. I'm not sure that's my picture, and I'm not sure whether people can hear me. But I will go ahead. Okay, good. May I have the next slide? So we conducted an anonymous survey, mostly during June of this year, and about 2,800 of all of us, nearly 10% of us, did participate. So I want to thank everyone who did. Next slide. And what we see here are some of our main findings in terms of what we are experiencing. And about 61% of us were feeling burned out, and less than half of us felt valued by Michigan Medicine when these surveys were taken. And moreover, 60% of those who identified as either Black or African American felt upset by how they were treated due to race in the past 30 days. And this supports the formation of the Anti-Racist Oversight Committee that our leadership recently established. Next slide, please. These are the other data that we found. More than half of us are worried about exposing ourselves and our families to COVID. More than 40% are experiencing either workload overload, anxiety, or depression due to the impact of COVID-19. Next slide. So When asked what would improve your ability to sustain through this COVID-19 crisis, more than half of us responded 24/7 access to healthy food, and about 42% responded personal access to mental health care. And from the previous presentation, we can add to this family care. Next slide. So what do these results tell us? It tells us that we are asking to feel safe from COVID and from work exhaustion. We're asking to feel valued and treated fairly by Michigan Medicine. And we're asking to feel included in work decisions, particularly those affecting families. Finally, to have personal access to mental health care and 24/7 access to healthy food at work. Next slide. So this is a broad overview of what we can do. First, prioritizing our well-being is foundational to achieve our missions of clinical care, education, research, and our financial goals. No matter what we hope to achieve, we do that best if we are paying attention to workplace well-being. And as far as making it easier and okay to seek help for emotional distress, we are working with our learners to provide services with the Office of Counseling and Workplace Resilience, and several work groups have plans to make that happen and are near ready to implement them. So you'll be hearing more about that. Finally, and perhaps most importantly, is we all have a role to play, our leaders and ourselves, particularly in safeguarding our well-being. For example, we want to be included in executive decisions that affect families, and also measuring how we are doing. So if and when we do repeat this survey, please make your voices heard and participate. Thank you. And now I will turn it over to Dr. Desmond, our Chief Medical Officer, who will talk about readiness for a second wave of COVID and testing capacity. Thank you.
Great, thanks, Kirk. I'll talk to you a little bit about where we stand in the state of Michigan, what the nation looks like in terms of COVID-19. And as Kirk said, some of our preparations here, both on the inpatient and ambulatory care side. Dr. Spollinger was not able to be with us today, and so he asked me to provide this presentation. If we could go to the next slide. So this, people have seen before, this is a map of Michigan, which shows in the dark blue the counties with the largest number of COVID cases. As you can see in the red text, we've had over 100,000 total cases, about over 6,000 deaths in the state of Michigan. I think the good news here is that the masking and social distancing and the social interventions that have taken place have been effective. And while we are still seeing some new cases in the state of Michigan, that rate has been fairly flat for many weeks now. And so that speaks to the efforts that people are taking to keep themselves and others safe. We are seeing sporadic outbreaks, and there have been some recent news items around some outbreaks in schools. And so we're going to have to be careful as we see people returning to elementary schools and outbreaks that are taking place there. If we go to the next slide. So cases in the United States in general are also starting to decline and have been for the last couple weeks. That said, the total number of new cases per day is still higher than it was in March when we hit our peak, nationally higher in March, nationally higher than when we hit our peak here in March in Michigan. This graph from the MMWR and the CDC shows what the hospitalization rate has looked like in the United States for COVID positive hospitalizations. And you can see there was that large broad peak in the early part of this, and then a decline, and then this kind of second wave that has come up in the latter part of the graph. The last two data points here may change as this data gets modified as more information comes in, but overall that is somewhat encouraging that we're seeing lower numbers of hospitalizations, and that rate is starting to decline. And as I said before, the national rate of new cases is starting to decline, though still quite high. If we take the next slide. This is what our admissions to the University of Michigan Health System look like for COVID positive patients. As you can see, we had this large peak on the left, and the color code in the dark blue shows those admissions that come through the emergency department. The gray shows those patients that were transferred either from other emergency departments or other hospitals. And you can see that the transfer population played a large role in the number of patients that we were admitting. That's tapered off, and as I said, like the state of Michigan, has been fairly flat for some time. So our adult COVID admissions are quite stable. You'll see, if you look carefully at that graph, that there is still some contribution of transferred patients. The other thing that I'll point out is that not all of these are necessarily new diagnoses of COVID patients, but this is anytime a COVID patient may get admitted or readmitted. If we could see the next slide. As we have stabilized that COVID population, we've started to ramp up our care for patients that had had their care deferred during the height of the local pandemic here. And these graphs will demonstrate that both on the inpatient side with our operating rooms, and then we'll also show some ambulatory care data that shows where we are with the ramp up. So if you look at the graph on the left, these are discharges from all our hospitals. And the green graph is the all cases, and you can see there was a sharp decline around March and April when we significantly cut back in order to accommodate the COVID patients. Now you can see that that graph is starting to get close to returning to normal. The other graph on the right demonstrates that the case mix index, which is a measure of the complexity of patients that are in the hospital, has been rising over time. You can see that goes back until 2018. There was a sharp peak there in the March-April time period related to the complexity of the COVID patients that we took, and a number of those were related to the ICU patients and the transfer patients that we took. But you can see that that complexity, as we start to resume the deferred care and bring patients back into the system, is still rising. If we take the next slide. This is a comparison of our overall hospital census across all our inpatient admissions, and then also shows you what our ICU census looks like and our moderate care census. And the COVID population is that pink bar at the bottom. So you can see the green line is the overall census in the hospital, and that dropped dramatically as COVID increased. You can see the red line shows that increase in ICU care and now stabilizing out, and then moderate care again, kind of stabilizing out where we are, and you can see the pink bars at the bottom show that continuing small but present COVID population in the hospital. So right now, today, as I looked at the data earlier today, we have 13 adult positive COVID patients in the hospital. There are 2 pediatric patients, which are both PUIs, and 4 of those patients, 4 of the adult patients, are in the intensive care unit. If we go to the next slide. One of the key elements of ramping back up and delivering the care that was deferred during the height of the local pandemic and our response is activating our operating rooms and bringing our OR cases back online. And you can see this graph shows the daily case volumes in University Hospital, CVC, and the Mott ORs, and essentially shows that we're getting close to steady state. I'll show you in the next graph that we're not quite back to our pre-COVID peak volumes, but you can also see here that the small short bar towards the end of those clumps is the operations that take place on Saturday, and we're still scheduling operations on Saturday, though that volume has decreased a little bit over time. If we go to the next slide. This shows the comparison of our current activity with prior year activity. So the blue line is this year OR activity across the UH, CVC, and Mott ORs for all cases. The gray line in the background is the historical volume, and again, shows you the dramatic reduction that took place during March and April, and then that we're ramping back up and we're getting close to prior volume. If we go to the next slide. This is a quick summary of completed visits in July within ambulatory care. And the graph on the left shows you what July of FY20, so July a year ago, looked like, with over 160,000 visits. And then what FY21, July this past month, looks like, again, close to the same number of visits, slightly less than where we were before. But again, as we've talked about previously, significant portion of those visits being delivered through virtual care. The majority of that in the yellow bar there on the right are video visits. The gray bar at the top are phone visits. So certainly an ongoing part of our strategy to keep our patients and our employees safe is to really leverage that virtual care and be able to continue to manage a large volume of patients in the health system, but be able to do that in the most effective and safe way. If we go to the next slide. Another effort in order to streamline check-in within ambulatory care and promote safety and keep our employees and staff safe, you'll be seeing as of the rollout, which will begin on August 26th, e-check-in functionality within Epic, which will allow patients to do their check-in activities prior to coming to the clinic. This function, called Hello Patient, will also use the geolocation on the patient's phone to detect their presence when they arrive, and arrives the patient in MyChart. So when the appointment's scheduled, the patient will get a reminder on the portal within 72 hours of the visit, a text reminder with some e-check-in information. They can do that, and then when they arrive, they will automatically, if they activate the location function on their phone, automatically get checked in and arrive in MyChart, and we can avoid some of that contact with our check-in clerks. So again, another effort that's going to be taking place to keep our operations efficient, but also promote safety and safety in the clinics. If we go to the next slide. We have a policy around mask requirements for visitors and patients, and we wanted to provide this update and reminder for people that this is our policy here. We will provide patients in our ambulatory care settings who present with symptoms or PUIs or have previously been tested for or tested positive for COVID, and the appropriate PPE guidelines will be utilized. Symptomatic visitors may be asked to wait in their vehicles unless they're considered essential to the patient visit. And we also want to remind people that faculty and staff are required to complete the screening application and wear masks when they arrive in clinic. Again, all our efforts around keeping both our staff and our patients safe. While we know that there's COVID out there, though we don't have the same degree of widespread community transmission that we saw earlier in the pandemic. If we go to the next slide. You've seen this slide before, and this is really our planning around how we would respond should we see a large surge in cases. Our current state is really in that chronic plateau stage, and we saw that in the previous graphs. We're seeing a few cluster outbreaks, but none of those have required us to manage our capacity in any different way. And then we're always planning and concerned about the potential for a resurgence of the pandemic. I put this slide in just to remind us that we have two thresholds which would potentially reactivate the RICU based on the facility capacity that we have in the adult hospital, and that's really a summer and a fall and winter plan. And those thresholds are when we start to see 20 ICU beds occupied by COVID patients, or in the winter we can push that up to 30 ICU beds with our ability to improve our negative pressure rooms within our ICUs. Fortunately, as I said, we have 4 ICU patients in the adult hospital now, none in the pediatric hospital, so we're not near ready to have to implement that RICU activation again. We have ongoing work with creating staffing plans for the RICU from both the provider and nursing side, so we have some stability in that staffing should we have to reactivate. If we go to the next slide. Supply chain is still a risk for us, though we have smaller numbers of patients in the hospital. We have expanded to be compliant with MIOSHA, the use of N95 masks, and we spoke about that here. There's a number of elements that play into our management of the supply chain, and these items in the middle, and including laboratory supplies and reagents, are really some of the critical items that we are managing. So, you know, spikes in demand, raw material shortages, production capacity globally, and you know, obtaining supplies from non-traditional vendors are all things that will impact our ability to manage the supply chain. If we go to the next slide, there's a number of things that our supply chain team have been doing to be sure that we're countering those factors, and we will have adequate amounts of supply chain. So substituting with safe alternatives, I think we've seen that. Different delivery. We're certainly creating our own antiseptic spray and using the spray to do our own wipes as opposed to the pre-moistened wipes, which we are able to purchase. Sourcing from other vendors, as we talked about. Spot buys, where we can get a large number of supplies in one purchase. We have committed to an ongoing purchase program to stabilize our N95 supply chain. We are looking at a transition to reusable gowns for isolation gowns going forward. And then a number of other things around teamwork and support across the organization that have allowed us to manage our supply chain effectively and really never have an instance in which we did not have adequate supplies. We're continuing to refine our analysis of the burn rate or the utilization rate of our PPE and update our demand planning dashboards so that we're able to anticipate when that burn rate is rising and should we need to make different changes around our PPE. If we go to the next slide. And finally, this is the last thing I'll talk a little bit about testing. So we have dramatically increased our testing capacity here for PCR testing, and we have serology testing available as well. And I'll show you, my last slide will show some of that capacity. Our priority is really around testing symptomatic patients and then symptomatic individuals. And then second, those who may be asymptomatic but have a significant exposure. And that's really guided by our collaboration with public health for the community, with occupational health for our employees. As we anticipate, if there is going to be a larger volume of patients, COVID positive patients in the community, we may need to significantly expand our capacity for this asymptomatic exposed population for contact tracing in coordination with our public health colleagues. And we have to be cognizant that we may still need to manage some of the supply constraints, and particularly around testing. Those are swabs, media, and reagents. And we've done some creative things here to manage that in terms of creating some of our own media, looking at alternatives for swabs and alternative collection media. And then finally, we're going to need to manage our collection resources. So as we imagine that we may require additional testing or larger volumes of testing, we are expanding the pool of employees that we can utilize for obtaining specimens and the areas in which we can do that so we can distribute that more effectively. If we go to the last slide. This is a graph that shows you what our testing capacity has looked like over time. It's a complex graph, but that red line is the total analytic capacity that we have. And if you can read the scale on the side, those are tests per day. And so if you see on the right-hand side of the slide, when that red line gets up to the top there, we'll be doing have the capacity to do close to 3,000 COVID PCR tests a day. The blue and the yellow lines, which squiggle across the graph there, show you what our daily demand for testing and number of tests that have been resulted show. So you can see that early on, we increased our analytic capacity. Some of our testing constraints were related to supplies, particularly media and swabs at that time, but we've gradually increased the number of patients that are being tested. And now, towards these later weeks, we're starting to bump up against our current capacity. That said, by early September, we anticipate that capacity to significantly increase, as the graph shows, and we should have increased testing capacity there. That's my last slide. I think now we'll go to Keith Dickey, who will facilitate some question and answers. Thank you.
Thank you, Jeff. So we have quite a few questions in the Q&A. So I'll do my best here to batch them a bit, and we'll try to get to as many as we can. And any that we don't get to, we will of course address in the follow-up communications during the course of the week, as we always do. So let me start, Dee, with Dee Hunt, 2 for you. One, are there more layoffs coming? And then a second, just more technical question. Another attendee writes, my colleague has been trying to file for FMLA to allow for school-aged children childcare. However, it has been challenging to find anyone in HR to help process paperwork. Who should faculty be contacting for these issues? So Dee, if you could come online and answer those two questions.
I'm trying, okay. With regards to the question, with regards to who they can call for their FMLA paperwork, we ask that you call our Solution Center, and that phone number is 734-647-5538. You can also go to the Michigan Medicine HR website, and you'll see all the information related to FMLA that you can also see, and the phone number there as well. But we'll get back with you if you just call that number, 734-647-5538.
Great,
With
thank you,
regards,
Dee.
if we're,
I'm
I'm
sorry,
sorry.
yes, go ahead.
The second question was about layoffs, I believe. And with that, we are continuously looking at how we monitor our staffing going forward, what departments are doing with regards to their objectives, their goals and objectives. We're looking at our patient volume, and we're trying to make the best estimate we can with the staff we need. And as volume increase and staff stabilize, the work increase, and we can move forward from that. And that's our hope, is that we'll be able to maintain and increase our volumes and our objectives can be met.
Thanks very much,
Thank
Dee.
you.
Yep, appreciate it. Let's see here. Brian, I think there are a number of, Brian and Helen, there are a number of questions related to the dependent care survey. If you all, I'm gonna read a couple out to you. Many folks have commented that the survey seemed very childcare focused, and there are a number of folks who have elder care and elder care related burdens as well. And so one person asks if there will be another survey that will be sent out for people who do not have dependents but have other family care responsibilities.
Yes, the answer to that is yes. Actually, there is a group at the university that is preparing an elder care survey that will go out shortly. And so look for that in your email. That is an area that is also obviously problematic. And we probably the biggest changes have occurred with daycares being closed, and but also elder care facilities closed, and like and elder daycare and the like. So yeah, we realized that the survey was designed. If you went into the first question and then answered that you had a dependent greater than 18, it would have continued you in. But if you said you didn't, it would take you to the end of the survey. So that was a little bit of a flaw in our survey design. But we're hearing from many people about this, and it's in our view box in terms of understanding that elder care or dependent care for adults is in the mix. And so we are paying attention to that. And there is a survey that'll come out that hopefully better inform us what the issues are there, so we can try to help with that as well.
Thank you, Brian. In addition, there were a couple comments asking about whether the original survey might be reopened. One person because it just didn't seem like the response rate was as strong as it should be. And another from the internal medicine department saying that he or she, there was a glitch and was unable to actually access or respond to the survey, and wondered if that was perhaps a widespread glitch that kept others from responding.
Yeah, I mean, frankly, I don't think we'll be able to redo the whole survey again, just because we're working with a pretty short time window to try to. We're in the focus group phase now, so we'll be getting input from lots of people across all job families with the focus groups, including grad students, but all job families. And there was a glitch. If the survey was passed on from one person to another, that may be where that came in. But I think we've got a lot of information. The average return on surveys like this that are sent out to the whole Michigan medicine workforce, 20%, 25% is actually pretty good in terms of the response rate. So it wasn't like we had a low response rate compared to other surveys.
Okay.
We're still looking at 6,500 responses. I mean, that's a lot of data.
Yeah. Let's see here. If you'll stay on, Brian. Let's see. What are the plans for grad and medical students with kids, as well as, I think, postdocs with kids?
Yeah, I mean, they're in the mix. We've certainly included learners. There are learners on the task force, a grad student, and we are doing a separate focus group session with learners in the coming days.
Good. Let's see here, Brian, again. It appears that this survey was designed for faculty and learners, but the majority of responses were not from this group. That seems important to note that the frontline workers want help. There are few frontline caregivers on the task force. Please explain how this group was formed and why there are so few frontline workers.
Right, so it came out of discussions at the med school level, but we were really conscious right from the very beginning to try to put a task force together that had wide representation, and we did that. We may not have gotten one of every job family, but we wanted to try to keep the task force small enough where we could meet regularly and get going. But everything we've done, we've tried to reach out across job families and get input, which was a big part of the survey. And you can see that the majority of respondents to the survey were not faculty. They were people in other job families, and the great majority in patient services. So we're trying to reach out. It came out of the med school, I think, just as it was something that we were hearing a lot about and we're very concerned about. But we're working with Dee Hunt in HR and with nursing and with all the other employee groups within Michigan Medicine to try to come up with some solutions.
Great, thank you, Brian, on that one. And apologies here, I'm scanning just to see if I can. Okay, I'll let you go for a second, Brian. I may need to come back to you, however. Dr. Kolars, I have a question for you. The question is, can you elaborate on the discussions with Central Campus about learning pods and utilization of classroom spaces?
Yeah, thanks. That's an excellent question. And like most of the things we're talking about, it's very complex and unfolding almost by the day. The concept is, how can we make use of classrooms and other spaces that we're not using for formal teaching environments to allow students to study there? So for example, Central Campus is taking certain facilities, maybe the one closest to us is Palmer Commons, and trying to say, let's take those spaces, the conference rooms and things like that, and design them for students to be able to go and study and have safe spaces, but also good Wi-Fi hookup. There's a lot of balancing between this and executive orders and the policies of when we should be in places for essential work. But you just have to walk around our medical school and our center to see there's a lot of empty spaces. We have a lot of learners who need a place to learn. So we're trying to look to see if we can convert for example, our conference rooms into just quiet places for students to work. There's a number of faculty like myself who are not using our offices right now. We're not supposed to be using our offices right now, but can we, find a way to prepare them for learners to go and have access to? So there's 100 ways to do this wrong, but I think there are really good people trying to think creatively how to make our spaces available for the learning that we want to see.
Thanks, Joe. Okay. There are a bunch of questions about the ResponsiBlue screening app, all largely the same question, namely, why are folks who are working 100% remotely being asked to do this daily screening. And so let me take a shot at that. Screening is required for those that come to work, and they should obviously either use that app, which is very easy, or stop at the screeners that are at the station to do the screening. For Michigan Medicine employees that are working exclusively from home, it's not required to fill out the screen every day, but it is encouraged campus-wide. There's a sense that this is sort of a community responsibility, and so it would be helpful if people just take the 10 seconds to fill it out, even if you are never coming into campus at all. Let's see here. This next question, I think, goes back to Jeff Desmond. Jeff, how does touchless check-in work for patients with multiple same-day appointments? Most of the staff isn't clear on what the patient will need to do on the app. Have patients been notified? This seems like a big change.
Yeah, I think it is a big change for patients. The patients do get notified through the portal and the text message, as I said. The specifics of how that works for patients that have multiple appointments a day, I'd have to defer that to the implementation team. So I think that's a good one, Keith, that we could provide a more specific answer to in the daily ops update as it comes back. So let's be sure we answer that directly.
Jeff, a couple more for you. Whom may we contact if we wish to make equipment/supply donations?
Janet Eversese, our supply chain manager, has been managing all of those donations, and that's the person to get in contact with. I have to say, particularly during the height of the pandemic, we were overwhelmed and impressed by the community outreach and the amount of support that we had from the community with providing, supplies, PPE, and food and other things. So we certainly welcome that, and supply chain team is the group that will manage that.
Thanks, Jeff. And one more for you. Why are we not, and this may be Lorraine, if not you, why are we not reusing the N95 masks when the UV reprocessing was working?
Yeah, so there are risks and benefits for all these things. The management of the N95 masks, the reprocessing, the return of them to the floors had substantial operational costs related to it, and there are other challenges with it. So when we're at a point where we have adequate PPE, small numbers of patients in the hospital where we're requiring N95 utilization, and the utilization is low, and we're confident in our supply chain, excuse me, the benefit probably just isn't there for the additional effort that it takes. So we made a conscious decision to back off on that. Should we get into a situation where we have large number of patients or we're unsure about the supply chain, we have those tools available to us to be able to reactivate those for the reprocessing and the extended use in order to drive higher levels of conservation.
Very good. And a related question, have you thought about ordering more PPE, specifically masks and gloves, to have more than you need on hand? If you don't use it, you could sell the excess to labs at a reduced rate.
Yeah, sure. Obviously, great question. I think if Janet were here, she would tell you that she's ordering as much as she can. One of the interesting things that happens in the supply chain is what we order is not necessarily what we receive, as there's demand across the country. So many of these items are delivered either on an allocation basis and when we talk about lack of confidence in the supply chain, we just don't know how much of our order will be filled or when that order will be filled next. So we're certainly managing orders in order to be requesting adequate amounts of PPE, but we have to watch carefully to see what gets fulfilled and then what actually gets delivered.
Great. Thank you, Jeff. I may come back to you with some other questions. For Brian and Helen, not a question, but somebody asked, will the slides related to the dependent care survey be made available after this town hall? And I'm sure we can attach it to the to one of the next communications that goes out daily.
Yeah, we'd certainly be fine with that. We would be happy to have it disseminated.
Let's see here. All right, so maybe Brian, this is you as well. It's a longish statement and question. I have 2 children under the age of 5. I've been utilizing the family helper service to find a part-time nanny as both parents work from home and we choose not to return to daycare. Most students have been unable to support even a morning care schedule because of conflicting class schedules. How is the university adapting their virtual learning model to free up more students to be family helpers?
A good question, a complicated question. We have been in communication with the dean of the School of Education to try to see whether students in that school can potentially help. I'm going to probably have to take that back to Melissa Dorfman, who has a better idea of the full resources out there. But please try looking at the resources page that we showed in the slides, because that may have some information for you. But I'll take this question back to the task force as well.
Great. And is the Family Care Task Force collecting names of potential care providers? This person says he or she knows of some college-age people who are interested in offering their services.
Yeah, that's one of the things we have to figure out is in terms of the resources, are we going to be kind of a repository? Are we going to be able to put that on a site? So stay tuned. I would hope that we can make links for those types of things, but we obviously won't be in the business of doing background checks and those things for caregivers. So we have to whether we're going to make links to or be able to just compile these in a list. We'll see. We're going to have to let that play out for another week or 2.
Great, thank you.
Keith, this is Dee. Also on the campus website, you can go to the benefits section and there is an area for childcare where we have students who are interested in participating in this program with our staff and faculty. They can fill out a form and campus will process that for them if they want to help.
Great, Dee. And one question for you while you've popped in. Somebody asked why we did not have an employee engagement survey this year.
Our employee engagement is usually set for the spring. During the spring in April, we were in the midst of COVID. We wanted to make sure our patients and our staff were taken care of, and we decided to delay our employee engagement survey until next year.
Okay, very good. All right, with just a couple minutes left, we have quite a number of questions related to the students returning back to university, and I'll offer up a couple comments, and then Marshall, if you're online, if you could chime in as well. The range of questions is, how do we expect the influx of students to impact Michigan medicine? Do we have an estimate of how many students across the entire university will be returning for in-person classes this fall? And how are we going to handle a large increase in testing needs once students return to campus? And some secondary schools allow or require in-person learning. And I guess I'll just start by pointing everyone to the Maize and Blue blueprint, Maize and Blueprint link on the main university webpage. They are now posting really good information about returning to campus and the students returning, and they also have a link to daily refreshed testing of students and staff, including positivity rates, and they're even showing how many students are now either in isolation or quarantine, either because of a positive test result or an exposure that's caused them to need to quarantine. So lots of good transparent information there for all of us to continue to keep an eye on. But with that, Dr. Brody, do you have anything to add?
I'm very little. I'd say you hit all the high points. The only additional comment I'd make is that we will be getting additional communication from the campus next week. And I think there'll be a certain amount of needing to be responsive in ways that we can't really predict today. But between the president and also the University Health Service, there'll be lots of continuing communication as there is, as Keith just said, at these various sites.
And I'll just offer up one data point. As many of you are aware, all the students who are coming back to dorms that were asked to get tested pre-arrival, and those results have come in. Nearly 6,000 students tested, and the positivity rate was a fraction of 1%, 0.3. So students seem to be taking it seriously. We had high adherence to the request for that testing, and it looks like they're doing the right thing around social distancing, and it does not appear that we're going to be bringing in a heavy COVID burden into campus based on that stat. With that, it's the top of the hour, so we should be respectful of everyone's time and call this town hall. As I said, we will do our best to address the remaining questions that are still in the Q&A in the course of the communications during the week. So thank you all very much. Thank our speakers for their time and guidance. And Marshall, thank you for leading this town hall.
Thank you. Thank you all.